Hello and good evening. It's time to start our live event. It's good to be back and it's 8 p.m. UK time, so it's definitely time to start our event, and I hope you had a wonderful day already and are ready to learn a bit on what Dr. Yanina has prepared for you tonight. So as you can see, she's already with us right here. This is Dr. Yanina Samoilovich. I hope I said that correctly. Hi, Dr. Yanina. How are you feeling tonight?
Hi, Caroline. Yeah, you pronounced it correctly. So I'm
Happy to hear
okay,
this.
and I'm ready to help to start our presentation. And I'm happy to see all of you here today. So I'm ready.
Excellent. Happy to hear this. And let me just mention that Dr. Yanina is obstetrician-gynecologist, fertility specialist at International Center for Reproductive Medicine, and she is talking to us from the clinic in St. Petersburg, Russia. And it's already quite late for her, so already I would like to thank you for your time and for joining our initiative as well. And before we start with Dr. Yanina's presentation, let me mention that, of course, all the Stronger Together events are brought to you thanks to our ambassadors and partners as well. Without their support, it would be very tough to create so many of those live events. So, thank you so much for your support as well. And the topic for today is definitely an interesting one. What factors affect IVF success? So Dr. Yanina will start with her presentation, but right after the presentation, it will be time for your questions. So as always, just type those in the chat section, and I'm sure she'll be more than happy to help you out as well. And it is time to start the presentation. Are you ready to go ahead?
Yeah. Yeah,
Excellent.
thank you.
Let's do it.
Before we start, I'd like to thank you, Caroline, and your organization for this wonderful invitation. It's a great honor to represent our company, International Center for Reproductive Medicine, for patients from all over the world. And to begin with, I'd like to introduce myself. My name is Samoilovich Yanina. I work as a gynecologist and I'm specialized in reproductive medicine. I'm here to give a brief overview of my experience and background and to explain that doing all my work with pleasure, I find it really important and essential to get into contact with all my patients from all over the world, if it's possible. As I have already said, I represent the International Center for Reproductive Medicine. It was founded in 1992 in St. Petersburg, Russia, and it's one of the first IVF centers in the post-Soviet area and the first reproductive center in St. Petersburg. We not just witnessed the birth of this area of medicine, but took an active part in the process. We are still involved in the activities aimed at development and improvement of this kind of medical care in our country, such as renewal of clinical guidelines, participation in discussion of new rules, regulations, etc. The team of our clinic is an absolutely wonderful network of people, and you can see the most of them on this picture. And there are a lot of specialists who always want to help our patients. Our interest has always been in communication. We want our patients to be well informed, so we invite you to contact us whenever you want. If you have any questions, we are all happy to help, and thank you for this opportunity to represent us. Here you can see the main achievements of our center: first ICSI in Russia, first surrogacy program, and oocyte donation program, first pregnancy in a patient with gonadal diseases, first pregnancy with frozen eggs. The first cryobank of donors' eggs and sperm in Russia was also created in our clinic. And coming back to our topic for today, what are the major influences on IVF success? I want to tell you about such factors as the age of both partners, quality of gametes and embryos, embryo transfer and technique of embryo transfer, uterine factor, genetic factors, hematological factors, immunological factors, And such very important factor is a lifestyle. And talking about the age as one of the most important factor, we know that each woman receives an endowment of oocytes during fetal development. At the 4th month of fetal development, the ovaries contain some from 6 to 7 million oocytes surrounded by a layer of flat granulosa cells to form the primordial follicle pool. At any particular chronological age, the vast majority of oocytes in the ovary are present as these non-growing primordial follicles. Due to rapid loss of the great majority of the primordial follicles via apoptosis in the second half of fetal life at birth, only from 1 to 2 million primordial follicles remain. After birth, this high rate of follicle loss slows down somewhat, so that at menarche at least from 300,000 to 400,000 primordial follicles remain. During their reproductive years, their continued and gradually accelerated decline will cause numbers to have dropped below 1,000 at the time of menopause. Along with the decrease in follicle number, oocyte quality also diminishes, at least after the age of 31 years old, when fecundity gradually decreases. And I want to say a few words about paternal age also, because we used to think that father's age doesn't matter, and we don't need to know about it something. But in recent years, however, we realized the importance of paternal age, and paternal age of more than 50 years old is associated with a high percentage of epigenetic changes, high percentage of DNA fragmentation and DNA mutation within the sperms and impaired spermatogenesis. It decreases the success rate of our program of IVF programs, and we can find the risk of some kind of diseases in offspring like autism, psychological disorders like bipolar disorders, and so on. We have, talking about the quality of cells, oocytes and sperm, we have some protocols trying to improve the quality of eggs before stimulation. For example, for patients with polycystic ovary syndrome, we have such drugs as metformin or minoxidil, which have a positive impact on the egg quality in this group, or we can give the androgens for women with low ovarian reserve to try to improve the receptivity and a response of ovaries for the stimulation. It's important to treat endometriosis before the stimulation because it's very complicated disease with many steps of pathogenesis, and there are special drugs using for releasing the process of oxidative stress and alteration in the oocytes. Of course, personalizing of stimulation protocols is so important too, because it's an absolutely different way in terms of efficacy and safety, for example, for patients with low ovarian reserve and for their stimulation, and for patients with, for example, polycystic ovarian syndrome. Talking about some predictor factors, we are learning it, and such factors can be, for example, high level of FSH hormone, and we know then that the follicle growth and ovarian response can be lower and worse in such case. Talking about the sperm quality, we don't have a lot to influence, unfortunately, but we have urologists in our team, and they can help our men and our patients to choose the right treatment, antioxidants, vitamins to decrease their DNA fragmentation, for example. The quality of embryos is determined by the quality of cells, oocytes and sperms, and I have told some words about it. And the better embryo patients have, the more chances they have for a pregnancy and childbirth in the future. We have special classification of embryos on day 5, which includes cell number, how many cells an embryo has, percent of fragmentation, nucleation, and alterations, and cell division moment. Here on the picture, you can see the human's embryo division. We usually check the embryos on day 3. And here embryologists want to see an 8-cell embryo, and on day 5, when the best thing to see is blastocyst. And talking one more time about good quality embryo, what we want to have on the day of the embryo transfer, it's good or intermediate quality embryo according to the classification. It's genetically healthy parents, and we can check it with the blood test for karyotype. And of course, if we have PGTA tested embryo, we know more about its quality. Talking about working with cells and embryos, I have to say that the key factor here is a good IVF laboratory, of course. Our equipment is produced by the world's leading ART companies from Japan, Denmark, Germany, and the USA, and the latest technologies and experienced embryologists can provide the better quality of embryos, safety of all procedures, and higher pregnancy rates for our patients. We cannot to mention such an important factor as uterine factor, and nowadays at the age of ultrasound and MRI, all of gynecologists can easily find out what problems patients have in terms of uterus. There are congenital abnormalities which can cause an implantation failure, for example, or newly acquired anomalies such as polyps, myomas, or adenomyosis, adhesions in the cavity. Such a difficult condition as chronic endometritis, which can be determined only by hysteroscopy and histological examination of endometrium. And sometimes, as a result of chronic inflammation, we have thin endometrium with all challenges to treat it. And talking about an optimal endometrial thickness, it's between 7 and 12 millimeters, and we want to see a 3-laminar morphology on ultrasound on the day of embryo transfer. Endometrial environment is very important, and I know that high concentration of progesterone, for example, on the day of the trigger administration during ovarian stimulation can cause an incorrect endometrial receptivity on the day of embryo transfer. Hydrosalpinx as a reason of chronic inflammation in abdomen, and this inflammation process can reduce pregnancy rates for 50% and increase miscarriages for 50% too. If a patient has mono or bilateral hydrosalpinx, it has to be removed by laparoscopy before an IVF cycles. It's mandatory. Leiomyomas can impact negatively too, because it can alter the blood flow and increase contractility of the uterus. And of course, submucosal myomas can deform the cavity and cause the defect of implantation. And nowadays, there are some tests such as ERA test for prediction the window of implantation, and ELIS-EMA test that can determine the endometrial microbiome and make us know if a patient has endometritis or not. And embryo transfer is as a final step in IVF. This is a final and very important step of the whole IVF procedure, and it can take from a couple of seconds to a few minutes. And what are the main factors that can affect the embryo transfer? First of all, it is the experience of your doctor. Most of us prefer to do an embryo transfer under the ultrasound control. The presence of much cervical mucus can affect the efficacy too. The catheter type, soft, is usually better to make the whole manipulation gentler and easier without any blood of the top of the catheter at the end. Is it important to stay in bed after transfer? Usually not, but our patients can have a 20-minute rest in their rooms, staying in bed if they want to, because we remember that psychological state matters too. Talking about such complicated aspects as hematological aspects or clotting alterations, and talking about thrombophilias as about a group of alterations coming from the coagulation cascade that can alter the functionality of the coagulation cascade. So one can develop microthrombosis, and that microthrombosis can have a negative impact on what will be the placenta of the baby, for example. They can create blood clots and alter the blood flow between the baby and the mother. So sometimes heartbeats can stop because of microinfections that are caused by those blood clots. They just obturate the arteries and most veins of the placenta. Thrombophilias can also cause, for example, heart attacks, brain icters, thromboembolisms, and so on. So we can have thrombophilias that have other manifestations, not only related to pregnancy. Sometimes we have women who miscarry because of thrombophilia, but those are very little proportion of the population, and they can be treated with such drugs as heparin and aspirin. It's drugs that prevent those blood clots from forming. And these conditions are usually treated by hematologists, and fortunately, we have this kind of specialists in our center too. And when we talk about immune factors, we also have to remember that the implantation process is always a crosstalk between an embryo and the endometrium, and so many immune factors, and you can see it on this slide, so many immune factors and substances take part in it. And there is a specialist who is called immunologist and who can help our patients to go through that kind of problems. Talking about women with recurrent pregnancy loss or thrombosis in her history, we should check her for such difficult condition as antiphospholipid syndrome. Using these blood tests, you can see it on the slide. And natural killer cells are a type of lymphocyte circulating in peripheral blood named because of their effective functions in killing target cells. Immune cells that share similar phenotypic characteristics but are poor killers populate the uterine lining at implantation and during early pregnancy when the placenta is established. The functions of these uterine NK cells are essentially unknown, but available data point to a role in regulating placentation in concert with other elements of the decidua and invading trophoblast cells. Despite the lack of scientific, rational, and advice from clinical governing bodies such as the Human Fertilization and Embryology Authority, an increasing range of tests and therapies are still offered to women undergoing IVF or attending recurrent miscarriage clinics based on the myth that uterine NK cells need suppressing to prevent damage the embryo. New treatments can be introduced at women with subsequent demands for expensive trials to prove or disprove their efficacy. And the evidence that targeting uterine NK or peripheral blood NK cells assists women with recurrent pregnancy failure is still lacking. And healthcare professionals and patients should very carefully evaluate the practice of immunomodulation to enhance pregnancy outcome. A discussion on how to move towards stricter regulation of immunotherapy in non-hospital settings is now needed because it's clear that the potential risks and costs of these therapies can outweigh any benefits, and we still don't know if it works or if it doesn't work. And here are some factors which depend on you personally, and I want to mention some of them. And the first one is body mass index, which reflects the relationships between your weight and your height. And the optimal mean of BMI is from 20 to 24, and you can calculate it easily on Google Online, for example. And we know that if a patient is underweight, it can cause such trouble as anovulation, for example, as far as the obesity or overweight can increase risks of complications during pregnancy, such as gestational diabetes, hypertension disorders, preeclampsia, and preterm birth. Moreover, there are some data that underweight or overweight can affect the cell quality also. And we know that it's incredibly hard to change your weight by yourself. So we have specialists who can help to do it. It's an endocrinologist and psychologist who can help to cope with this problem for you. Physical activity and exercise, and you should find the middle spot here, because too much of physical activity is not good. And we can see professional sportsmen, for example, as an example. Women can lose their ovulation because of too much of sport and their fertility as a result. But many of us have sedentary behavior, and we know that physical activity exercises should be included in your life, and moderate exercise decrease the risk of miscarriage and increase the chance of success among women who undergo ART and IVF programs. And a minimum of 1 hour exercise 3 times a week improves rates of implantation and pregnancy and reduces the risk of miscarriage. Talking about caffeine as about an important part of adults' lives, and it's necessary to know some facts and to understand possible harm about it. We know that it's one of the most psychoactive components, and it could be found in more than 60 plants. And it exists in cellular, breast milk, embryo, and neonates as it passes membranes and placenta as well. And we must know that caffeine presence not only in coffee, but in tea and chocolate, soft and energy drinks. But it's still not clear if caffeine affects the chances for pregnancy. So expert advise limiting caffeine if you are trying to conceive, and during pregnancy fewer than 2 cups per day. Talking about alcohol, it's clear that heavy drinking increases the time it takes to get pregnant and can affect a developing baby's health. And for women, the best option is to avoid alcohol when they are trying to conceive. Men trying to conceive should limit alcohol to no more than 14 units a week. Emotional adjustment in couples with infertility is so complicated, as they have to deal with stress of infertility diagnosis, infertility-associated identity crisis, dealing with ongoing infertility treatment, and high possibility of unsuccessful treatment cycles. And that's why we have two psychologists in our team, and their schedule is always full, and they can help our patients to go through that difficult way to pregnancy and meet their child. And in conclusion, I would like to say that we should be a team, I mean a doctor and a couple, and both should do all their best to reach the goal, to meet a child. And one of the main principles of treating is to individualize characteristics of each patient and to adapt medical treatment to the individual characteristics of each patient. And here is my contacts, and here is the address of web address of our site, of our clinic, and don't hesitate to contact us if you have any questions. And now I'm ready to answer your questions if you have it now.
Excellent. Thank you so much for this presentation. Lots of details you have provided, lots of factors that can affect IVF success. So thanks for this. And yes, you are very right. It's time to start our Q&A, and there are actually lots of questions ready for you. So are you also ready for them?
Yeah.
All right, excellent. Let's go ahead with the very first one. You have mentioned this already, but if you could perhaps just explain once again, why is 41 considered as the end of fertility?
The advanced maternal age is supposed to be a very difficult case for infertility treatment, and it's important to know how many follicles in your 41 you have on the ultrasound picture, and it's important to know what story have you had before, and no, it's not clear to say that 41 is the end of fertility, and every person, every woman has her own age for it. So for someone, it could be 41. For example, some days ago, I had a patient. She's 43, and some days ago, she delivered a baby by herself with not donor's eggs. So no, I can't say that 41 is considered to be the end.
Perfect. Thank you so much. And actually, there's a follow-up from the actual same patient. So in which cases would you recommend donor egg for women over 40?
It also depends on what history have you had before. If you had a lot of attempts with your own eggs and it all failed, so maybe it's useless to go ahead with your own eggs. And if you don't have any good quality embryos with your own eggs also. But if it's your first time and you haven't tried it before with your own eggs, so you can try it if you are 40 or if you're from 40 to 42. I think that the biggest age of you when you can is the oldest age of you when you can try it with your own eggs is 43, 44. But again, it depends on a particular case.
Once again, thank you so much for the explanation. And let me have a look. And if you could provide some supplements that you could recommend for eggs and sperm quality.
You must understand that supplements it's vitamins and different other substances, and there are not a lot that, for example, can raise the quality of sperm or eggs. And for example, folic acid is proven vitamin that both of partners have to take. But different antioxidants coenzyme Q10. What else? There are a lot of different supplements that doctors can advise now. Yeah, it's not bad, and I'm not sure it can do some harm for you, but for example, the most unfortunately, the most important factor here is your age. If we talk about women, so if you are an advanced age, there are no many supplements that can help. So the age is the best prognostic factor. And talking about sperm quality, it's important to remember that we have urologists that can affect the sperm quality somehow with some antioxidants. Yeah, they can advise it, but also lifestyle of men can do much more, and diet and avoidance of cigarettes and alcohol than taking any supplements.
And thank you so much for your question, indeed, as well as your answer and clarification to that. Next question, it's a bit longer one, so let's have a look. So I have embryos from a young proven donor and my husband's sperm, and apparently good quality embryos. Neither donor or my husband have any similar carrier diseases. I will be using a surrogate and concerned regarding epigenetics, which might switch on any of their own carrier diseases. What is your view? Should I also try to match my donor's blood type with the surrogate blood type? Thank you.
Oh, such a long question. Um, Blood type is not as important as the rhesus factor. So it's better to have this if the donor of eggs has a negative rhesus factor, it's better to surrogate mother to has the same. But it's not about blood type. It doesn't matter.
Okay, thank you. Angela just confirmed here that both results are positive. Um, and let me
So
just.
yeah, if both rhesus are positive, so
Mhm. And could you also say something about here that Angela
ep-
asked when it comes to the epigenetics?
epigenetics, it's better to ask genetic specialists about it, because now we are only in the beginning of understanding of all epigenetics process. So I'm afraid I can't tell a lot about it. So it's better to ask genetics and biologists about it.
Of course, understood. Thank you so much for this question, of course, and your assistance with that as well. Next question is right here as well. So, would you consider treatment for women with fibroids?
It's supposed to be treated, but it depends on of the kind of fibroid. If it's submucosal fibroid, it is definitely should be removed before an IVF cycle, before embryo transfer, and it doesn't depend what size it has. It should be removed. If we have intramuscular myomas, it depends on its size, and we here in Russia, it's legal not to remove it if it doesn't deform the uterus cavity, if it's not more than 4 or 5 centimeters. So yeah, we should treat it, but it depends on of the kind of fibroid. Maybe you can describe it, and I will tell something more.
All right, understood again. Thank you so much for that. And there's another question, which is a bit of a longer one. Okay, so let me show you this. So I have endometriosis. Adhesions were cut but are not removed as endometriosis on my uterus too. I can feel my endometriosis symptoms have increased since my operation last year. I also had a septate to uterus, which was operated on. My endometrial lining was 3 millimeters 2 months ago, and I am currently taking estrogen before I start IVF in December. Hopefully, my AMH is low. I am doing the Mediterranean diet, supplements. Is there anything else I can do to help myself? And increasing my uterine lining. Lastly, how long to rest after egg collection?
Endometriosis is a chronic disease, unfortunately, and it's important to know how many follicles in your eggs you have now, and is it diminished or not, and it's important to understand what your IMH level also, and it is also important to understand what treatment of endometriosis have you had after your operation, because it's better to have complicated treatment, not only operation, but the complex treatment with drugs also. It could be digest special drug for the endometriosis, or agonist special injections. And talking about your uterine lining, yeah, you can use high doses of estrogens, but we also know that it doesn't help always, and there are some other factors that can help. For example, here in our center we try to use autoplasma injections of autoplasma, and we use it twice in the cycle of the transfer of frozen eggs, and it is safe to use. This plasma can stimulate proliferation and regeneration by growth factors and cytokines that are inside this plasma. And we can't say that it's a proved method and it always helps, but it's better than to do nothing, and we have to do something when we want to improve the endometrial lining. And how long to rest for after egg collection? You mean before planning an embryo transfer, or you mean at the day of an egg collection? How long have you been in bed? If you mean how long have you stay in bed after egg collection, it depends on you. You must feel well, and you don't have to feel dizzy or something. Usually it takes about from 30 minutes to 1 hour, and then you can stay and go home. I hope I answered most part of the question.
Wonderful. Thank you so much. And actually, there is another question from the very same patient. So let me go through that. Okay. It's regarding the supplements. And age, I am 34 and a half, low AMH, with taking 600 milligrams of CoQ10 and 200 of vitamin E help increase my endometrial lining plus egg quality to prepare for IVF.
Yeah, also we can recommend, except what you have already take, we can recommend the vitamin D, 4,000 units in a day, but that's all, and healthy lifestyle, and I'm not fond of prescribing a lot of supplements. I want to prescribe things that have proven data to be prescribed.
Of course, that's understandable. Thank you so much. And actually, there is one more question in regards to supplements. If you could take a look, still, if zinc and honey can increase the quality of sperm morphology and quantity.
I'm not sure about honey, but there are yeah, a lot of different um, not professional data about it, but zinc, yeah. And we can see that our urologists can prescribe it for men. Zinc, selenium, and folic acid are very useful for sperm quality and quantity.
And excellent. Thank you so much for that as well. And sorry, one more. Okay. What is the ideal vitamin D value for IVF? What is too high?
I think that every laboratory has its own reference meanings. So we have the reference meanings that vitamin D should be more than 30, 40 units in a blood. But I'm not sure that your laboratory has the same reference meaning. So it depends on the laboratory.
Okay. Again, thank you so much for the clarification. And there's a thank you for from the patient. So thank you for answering as well.
Yeah.
Okay. Perfect. And let's have a look. Of course, there are plenty more questions coming up. So, what dose of FSH does one follicle need daily to grow mature egg in a natural cycle and in IVF?
If we talk about natural cycle and if it makes sense, we are not fond of prescribing a high dose. So we should prescribe a dose from 75 to 150 units of FSH. If we talk about low ovarian reserve, if we talk about low ovarian reserve, not only not about the natural cycle. If you talk about natural cycle, we shouldn't prescribe any of FSH. So that's why it's called the natural cycle. And if we talk about usual IVF, we should use the middle dose of FSH. It's from 150 to 225 units of FSH.
And wonderful. Thank you so much for this again as well. And let's have a look. Of course, there are more questions coming up. So here's the next one. So how does high sorry, just give me a
Yeah, can,
male fertility. Okay, use of weight impact male fertility. Okay.
yeah.
Sport.
If we have high sport, hard sport, you mean? If you have hard sport and if you're a sportman, and if we talk about women, women can lose their ovulation and their fertility as a result, and that's how it can impact their fertility. And if we talk about men, um, who is um, who is using some supplements, some hormonal supplements, it can affect the sperm, the quantity and the quality of sperm. High impact and weight training for men. Yeah, if you use some supplements, it can be harmful.
Excellent. Thank you so much once again for the clarification to yet another question, of course. And again, there's another question. So, at what point should you be exercising to increase likelihood of implantation before or just after embryo transfer?
Uh, no, it's better not to exercise after embryo transfer, definitely. And but you shouldn't stay in bed. You should live your usual life and you should walk. Uh, you should maybe swim or do yoga, but not hard exercises when you have already done the embryo transfer. And before embryo transfer, you should do regular exercise to make better your blood flow in your pelvic, for example. So I hope I answered.
Once again, thank you so much for that. Let's have a look, okay? Next question is, so does the body weight influence the impact of the dose of FSH during stimulation?
Yeah, definitely. And we often can see that women who overweight or who is with obesity, needs more FSH dosage during stimulation, and sometimes we can see that there is no growth of follicles, and we should use more and more, and we should increase FSH dose, and even and sometimes it's even useless, even if we rise it. So it's better for that kind of patients to lose their weight, and as I have already said, the optimal BMI should be from 20 to 24, and you can easily calculate it with different calculators on Google Online.
And once more, thanks a million for explaining another question. And let me just go. We have a follow up, okay, from the previous question. So, when would you recommend taking time off work, before a collection or after?
Or after egg or transfer. At the day of the egg collection, definitely you should stay at home and you should stay in bed, because it was an operation with your eggs, and there are some risks of bleeding. So it's better to avoid work this day. And if you don't have any hard work, you can easily work after the transfer.
All right, excellent. Thank you so much for that. Once again, there's a thank you from the patient for you as well. And let's have a look. Of course, there are like few questions left. We will be slowly finishing. So if you have any questions, just go ahead and type those in right now. And the question is, intrauterine fibroids can affect implantation, and what size must be treated before starting IVF treatment?
Mhm. If we talk about fibroids that deform the uterus cavity, it must be treated, and it doesn't depend on their size. And if we talk about the fibroids that don't deform the cavity, it depends how big it is. And we here in Russia, we operate the myomas more than 4-5 centimeters.
All right, perfect. Thank you so much for this one as well. And the question from Karen is, I have AMH of 6.1 picomoles, and the majority of follicles are on the right ovary, with typically only one follicle on the left ovary each month. Is there any way I can wake up or do something to encourage more activity of the left ovary?
Unfortunately, I don't think so. So if you have more follicles in your right follicle, so let it be, and your IMH level is quite okay. So it's easily can be treated with IVF, and you can get a lot of oocytes from your one ovary and only one egg from the left ovary. It doesn't matter. Matters the whole amount of your oocytes. And no, I don't think so that you have do something to encourage more activity of your left ovary.
All right, understood perfectly. Again, thank you so much. And there's another question from Karen. So let's go straight to this one. What is the benefit of low dose stimulation versus traditional IVF where the woman has low AMH? What do you consider a low AMH?
Um, Low MH is considered to be less than 1 nanogram for milliliters here in Russia, and there are different references. Meaning, it depends on the laboratory too. Maybe in your laboratory you have other. Um, but if the MH level is low, we it depends. It depends on the age of a patient, and it depends of the level of FSH hormone. If the level of FSH hormone is quite high, more than 12 or 15, we have to use high dose to make ovaries and follicle in ovaries grow. If we use a low dose of FSH here, our ovaries won't produce any follicles. So there is not much information. Maybe you can tell me something more. So it depends on the age and it depends on the FSH level. So not too much information to answer correct your question.
All right, understood. Once again, thank you so much, of course. And I just oh, sorry, sorry, Karen
Yeah, I
has
see.
added some
Mhm.
information here, as you can see.
Yeah, I see. My FSH is 9 and IMH is 6. And there of antral follicle number 6 and age 42. And I would try the middle dose of FSH here, about 200 units of FSH, maybe with LH activity, gonadotropin with LH activity. But again, I don't know your previous story. Maybe you had something in your past, and it was failure. So what I can say, only looking at these numbers. So the middle dose.
All right, excellent. Again, thank you so much. And of course, there's a thank you from Karen as well. And there's one more, okay, from Karen. So does there need to be a minimum time between significant weight loss and IVF treatment?
Uh, of course, it's better to lose your weight and then to do IVF. But if you are 42, you don't have enough time. So be in a hurry and don't waste a lot of time for losing the weight. Just do IVF as you are.
All right, thank you so much for that advice, recommendation, and of course, thanks from her as well. Here, thank you. And it's in regards to the previous question, in regards to LH, what is the benefit of LH?
Um, we um, we tend to use LH for people in advanced age, at the age of 35. We also use it when we had some failures with the only FSH using in previous attempts. And there are a lot of data that LH for women of advanced age can have some benefits according to the eggs quality.
Thank you once again. And it seems that this will be our final question for today. All right, so let's have a look at it. What is the maximum age for a woman to get treatment at your clinic?
If we talk about donors X, maximum age in our clinic is 54.
Excellent. Thank you so much for the clarification to this one. And well, there I don't see any questions. Of course, we will be finishing, but I just want to mention that if anyone would like to get in touch with Dr. Yanina and her team, I have just sent you a link. You can use that. There is a contact button, and of course, all your requests will be sent directly to the clinic. So if you missed something or if you would like to get some more details, just go ahead and do it. I'm sure they will be more than happy to help you out. And of course, as you can see, Dr. Yanina, there are many, many thank yous coming up. So thank you so much as well for joining us tonight, for your time. I know it is quite late, but I'm very, very happy that you've decided to join us tonight. And you can see there are plenty of thank yous as well.
Thank you so much too for invitation, and that's our the only way to communicate in these difficult times. And I hope to see some of you, maybe all of you, in our clinic someday if you need it.
All right, excellent. Actually, as you can see, someone has already mentioned, hope to meet you again. So, as you can see, many, many of those things coming up your way. So, thank you very much for presentation and answers to the questions. And all right, happy to hear that. Um, okay, as I mentioned, there is a link. Okay, but of course, if you would like to get in touch with Dr. Yanina, there is a link. There is a contact button. After we finish this one, you will be redirected to contact Dr. Yanina, so you can go ahead and do it. And well, remember, it has been recorded, so it will be available on our site, which is My IVF Answers, tomorrow. So I hope you will be able to see it if you missed any parts, of course, of this. And also remember that it will be uploaded on our YouTube channel. And if you would like to see some of our past webinars, also you can find them all on myivfanswers.com. And I can only encourage you to well, register for our events. Tomorrow we will be back at 8 p.m. This time it will be a doctor from Greece, as this is Friday, and therefore we are having the Greek doctors with us. And Dr. Yanina, thank you once more for this. It's been a pleasure to have you with us, and I hope to simply see you once more. And to all of you, thank you for your questions, very interesting ones, and for your time as well. Hope to see you all here back as well. Dr. Yanina, have a lovely evening. Everyone else, wherever you are, have a lovely evening or have a great day. And once more, thank you so much.
Thank you, Caroline, and good evening, good night.
Perfect. Thank you so much. Bye.
Bye.